just going through a few other things that were in the final rule that were changed that are exciting. Virtual direct supervision. So this is particularly exciting for folks who are doing like preventative services and other services where it does not have to be done by the physician or the mid-level or billing provider. It can be done under supervision, direct supervision by clinical staff. Well, during COVID, CMS sort of adopted this definition of direct supervision where a person can do it remotely from the physician as long as the physician was immediately available through real-time communications technology. Prior to this, there was this whole sort of somewhat like arcane set of criteria as far as like how are you immediately available. So if the nurse is doing annual wellness visit prior to virtual direct supervision, it was like, well, is the doctor in the same parking lot? Are they across like the Skyway? Are they within walking distance? And there was these sort of sets of criteria where were they immediately available. During COVID, that changed, like I said, to where as long as you can go ring and audio visual the doctor, you counted that as as direct supervision. They are now making that permanent for all Institute 2 services, except for a few high-risk ones that they're excluding out from it. But for all intents and purposes, the vast majority at this point allows the virtual direct supervision now. CMS, it's actually interesting. There's an overarching theme to a lot of these things where CMS is saying, same thing with the RPM measurement changes. They're like, we're making this more expansive and inclusive under the assumption that you understand that this is an option, not a mandate, and that supervising physicians should be deciding case by case when you can do this, right? So there's a bit of, and it might behoove sort of documentation changes, things like that, to show, when you feel like something can be done virtually versus not, and why, and things like that. And FQHCs, RHCs have a mirrored requirement now for virtual direct supervision. So exciting, sort of, I guess it's not that exciting given that this is how it's been for a long time now, and they're just sort of making a permanent, permanently adopting the COVID waiver for the most part, except for those high-risk services, but still something that's relatively, it's good that it actually went through, because they did go back and forth on this one for quite a while. Really quick updates about FQHC RHCs. I see we do have a couple dozen RHCs on the call, but I won't go too deep into this. But basically, there's also some takeaways you could take from this more generally about APCM, right? So Advanced Primary Care Management, released a couple years ago now. Basically, it's chronic care management where you don't have to spend time, or at least you have to spend time, but you don't have to record specific amounts like 20-minute increments of time with the patient to bill. The industry, myself included, thought that this year that they would go through APCM and maybe be a little bit more explicit about the requirements of it, because really it is kind of, it's not vaguely, I guess it is, it's kind of vaguely sort of defined, and it sort of allows for billing without time spent explicitly with the patient. So we expected it to be a little more, just have more regulatory sort of, stuff around it and requirements around it. We didn't get that. We kind of got a full-throated, like, hey, we like how APCM is going so far. And on top of that, for FQHCs, they unbundled from APCM they didn't unbundle. They have now BHI add-on codes that can go along with APCM for FQHCs and RHCs. Mostly behavioral health integration, and then the collaborative care model for behavioral health and mental health. So expanding out APCM that way, so now you can do BHI in addition to APCM if you're an FQHC, which really more generally is sort of just showing that Medicare's all in still on the APCM service in general, and it's going to continue to. Real quick, also, communication technology-based services now are also being unbundled from the FQHC billing schedule, which is interesting because the whole point of the FQHC billing schedule, since as long as I've been practicing and in this industry, was we want as few codes as humanly possible. And it seems that Medicare is starting to unbundle more and more codes from that all-in one visit code. So the the virtual check-in codes and things like that now are being unbundled and billable separately, in addition to the ones that already were, like RPM, CCM, and the other care management codes.